Really?
Yeah, I've seen everybody right now. So, yeah, whenever you bring up a laptop, laptops like to be like, oh, we're gonna extend this because everybody wants more desktop space.
Oh, wow.
Yep, that's been one of my big calls today. Okay.
All right, wait, come back here 1 second. I think I just lost it again. You said right click this little desktop icon here?
No, just right click on the desktop itself.
Anywhere.
Yeah, on the desktop. There you go, just place it.
Just place it. Okay, I got it. No, no. Yeah. Okay.
Yeah, everyone.
All right, so let's go to the syllabus. I think everybody knows that the plural of syllabus is syllabi, by the way. That's right. Okay. So what I was saying is that at the end of the last semester, they came up to us in our department meeting saying, okay, we have to split all the biology courses into lecture and lab. Some of the splits really don't make any sense. For instance, the histology course is really primarily a laboratory course, but they made this split it into 3 hours of lecture and 1 hour of lab, which makes no sense. So I argued that nobody else does it that way, and so they corrected it for the next year. So, in any event, we're having 2 different time slots here, one for lecture, one for lab, although, I'll be honest with you, we're probably not going to stick to that. We'll probably use some lab time for lecture and vice versa, okay? But you'll have a separate grade for both, that's the idea. Now, I'd like everybody to read the syllabus, and I sent you a link to a practice exam that you can take using the new lockdown browser. Part of that exam, well, read the syllabus before you take the exam. All right. The books, 2 different books. One's a cardiac physiology book, this bad boy. It looks very innocent because it's skinny, looks like it'd be easy to read. Not the case. Every single word in this book is important. You might read 5 pages, and at the end of the 5 pages, you'll ask yourself, what did I just read? A lot of times you have to go back and reread. But this is the same book that's used in the medical schools. So if you get a head start on it now, it'll make it easier down the road. We have a similar book for the pulmonary component. Now, after Thanksgiving, we're going online. Everybody is. So, in addition to the usual requirements, you have these requirements for like a laptop or computer. It has to have a webcam. Because when we use the new lockdown browser, they have to be able to see you the entire time you're taking the test. So if you've taken one of these lockdown sample quizzes, you'll understand what I'm talking about. Has anyone done it yet? Okay. So what you'll do is you have to download the browser, and if you take a test or quiz online, you have to use the browser. What it does is that it prevents you from then going from that particular site, Canvas, and pulling up Google or some other site. People did that. The other thing it does is it watches you while you're taking the test. So for instance, we've done some sample quizzes, and students are unaware of what the requirements are when they first took the sample quiz. They were doing some things that caught the attention of the monitor. Okay? For instance, they may have simply, while taking the test, they may have simply gotten up like this and then sat back down. Well, it red flags you if you do that. Or, we've had students who have done this for a period of like 20 seconds. It's going to flag that. You need to be looking into the computer. Okay, if you talk, that's a no-no. It'll catch you for that. So it's really the same. So the standards for taking an online test are the same as those for testing centers. Like in a testing center, you can't, get up from your chair. You can't, look away into outer space or anything like that. They monitor you. What else did I want to say about that? If we do any Zoom sessions, you have to show your video the entire time. That's why it's important to have a webcam. All right, for the lecture part, which is 3 of the 4 hours, you can have 5-minute tests, there'll be quizzes, and then a research paper. That counts for 20%. We'll talk more about the research paper later. Attendance. If you come late, it's important to notify me during the break between the two sessions, so I can convert your tardy, your absent to a tardy. And the reason that's important is your grading depends in part upon absences. For instance, if you have 4 absences, you can't do that. Or if you have, and so you don't want any absences to accrue, you'd rather have a tardy. If you miss 30 minutes of a class, regardless of whether you came on time or not, that counts as an absence. Okay. If we're doing a Zoom session, you have to not only be present at the start, but throughout. And that's why we need to see your face the whole time. Plus, it makes it more interactive. If I'm just looking at a bunch of screens with names on it, it's hard to teach that way. So what happened is the administration came in, because they provided us the template for the syllabus, and they made sure that we put in certain wording. They talked with legal. And they said, okay, you have to make sure you put in certain wording. So one of that, for instance, is by enrolling in this course, you agree that you're expected to show your face on camera throughout each class session and during each test session, and participate as appropriate. You're also consenting to having your image and voice recorded. All right. Anybody have any questions about the syllabus? Okay. Let's move on. You know, we lost today because of the storm. But we'll catch up. I have confidence we can do this. By the way, did you notice the new format for the website?
Yeah, you can like log in on a different.
Yeah, it's new kind of craziness. They're always changing stuff. Okay.
Why are we going online after Thanksgiving, Dr. Bennett?
Well, because what happens is people tend to leave town during Thanksgiving, visit family and so forth. And so the risk of someone coming into contact with the virus is higher.
Oh.
And so there's concern about that could cause a spike.
Right. That makes sense.
Today, we're going to kind of go back in time, to a simpler time, before the virus. Back to maybe your first or second semester, probably the second semester here at the Cross, when you initially enrolled in AP2. It was a wonderful time. How many people took AP2 here at the Cross over here? That's everyone. Good. Good. Excellent. And if you took it from me, you can see pictures that look very much like the pictures I'm showing you, that you remember from AP2. Some of these pictures are not coming out right. You see what's happening there?
Yeah.
Does that make a difference? Not really.
Maybe just try going back in back.
What's that?
Try going out of it and then go back in.
You mean leaving the site?
Yeah. Or just minimize the.
Let's see if we download it. Let's try this. Ah! It's not working. Yeah. You know, this is like the first day for everyone. Oh, I lost it again. Hold on. Must be. Oh, that's it. All right. So what I'd like to do today is talk about the heart. Because what happens over time is we tend to forget all the little details. Okay. So here we see an image of what the chest cavity would look like if we simply opened up the thorax. If we split the sternum in half with a saw and just pulled back the rib cage on either side. Retracted is the term we use. Now, what I want you to recall is that the heart sits in a space in the center of the thoracic cavity, between the two lungs. What do we call that space? The mediastinum. Now, the mediastinum not only accommodates the heart, but it accommodates the pericardial sac that surrounds it. It will accommodate the great vessels that come off of it, the thymus here, lymph nodes, the trachea, and posterior to the trachea, the esophagus. All of those structures sit within the mediastinum. Now, if I simply retract the rib cage on either side, exposing the mediastinum, I don't actually see the heart. Why? Because it's surrounded by a pericardial sac. I'm going to draw some pictures here. In histology, I did some drawing with my left hand, very minimal drawing. I'm going to stick mostly with the right for this class. Okay. So, here's the heart kind of sitting within the mediastinum, and this is the apex. What do we call this part of the heart, the broader end where the vessels come off? The base. So you see the great vessels either entering or exiting at the base. Now, I'm going to use blue to demonstrate the pericardial sac. One layer of the sac forms the outer surface of the wall of the heart like this. It actually moves up onto the great vessels a little bit like this. Okay? And that gets reflected back upon itself like this. Forms an outer layer. Okay? So we have an inner layer that forms the outside of the heart wall, and then we have an outer layer. Remember that the inner layer is called the visceral layer of the pericardium. Because the word viscera means organ. So because it's attached to the organ, this is called the visceral layer. The outer layer, what do we call that? Parietal layer. And these are the two layers of what we consider to be the serous pericardium. The pericardium is a serous membrane. By definition, a serous membrane surrounds a space or cavity that's closed to the outside. And this space, the pericardial space, is closed to the outside. It's not like, for instance, the lumen of the stomach that is open to the outside. So therefore, the epithelial membrane that surrounds it would be a serous membrane. Okay? Now, another term for the visceral layer would be epicardium. So epicardium and visceral layer of the pericardium are the same. Now, when we talk about the pericardium, we're really talking about these serous layers, the visceral and parietal layer. There's actually an outer layer of tissue that is superimposed upon the parietal layer. In other words, there's a thicker fibrous layer that sits like this, right outside the parietal layer. But it's not an epithelial membrane, it's made up of fibrous connective tissue. And it's going to attach to the diaphragm like this. Okay? So what you're seeing here, this layer of tissue that's then moving onto the surface of the diaphragm, that's the fibrous pericardium. But again, I want you to remember, if we use the term pericardium, unless I specify fibers, I'm talking about the two serous membranes, the visceral and the parietal layer. Most of that wall is made up of cardiac muscle. We refer to this layer as the myocardium. The innermost lining, which I'll draw in green again, is the endocardium. The endocardium is going to line the ventricular cavity here. So if I were to talk about the wall of the heart, if I were to cut a slice out like this, the wall of the heart consists of an endocardium, the thicker myocardium, and then the epicardium, which is just the visceral layer, the pericardium. Now, I'm going to tell a story that I think I've told most of you. It made a tremendous impact upon me as I was kind of trying to become a physician. I had, what happens after you graduate from medical school is you start your internship, and you do a year of internship. And for me, I did what was called a rotating internship. In other words, instead of simply doing, let's say, internal medicine, I rotated through a number of different departments: surgery, anesthesia, dermatology, to give a broader background. And then, what happens is you start your residency. Okay, so my second year, first month of residency, they assigned me to the charity hospital, to the emergency room. I was what they call the charge resident. And I remember talking to the program director. I said, I don't know if I'm ready to be charge resident yet. He said, oh no, you're good. You'll grow into the role, okay? So this was July 1st of my second year. Now, when you charge residents, you supervise all the people under you who are interns and nurses. The nurses are usually there for a long period of time. The interns all rotate through. So all of the interns in July have never really been a doctor before. This is their first experience. They've just been in medical school. And so, at the charity ER, you had 4 different departments. You had so here, you had a turnaround in the back of the hospital. That's where ambulances come. This is the old charity. They have made movies about this place. So there's a turnaround, and here's the building. And right inside these open doors, there's a little triage desk. See? So you assign one intern to the triage desk. He's gonna be the intake person. He's gonna evaluate the person coming in right away and assign them to one area of the ER. Over here, what's called the accident room. This is for surgical emergencies. Right next to it is the GYN room. We call this the cockpit. This is for like GYN emergencies and pregnancies and things like this. Then here was the West Admit room, or this was for medical emergencies like congestive heart failure, cancer, whatever it was. And then over here, you had the pediatric emergency room. So the guy in triage says, okay, nurse, move that person over here, over there, over there. I mean, sometimes like on a Saturday night, you're moving quickly. Now, as the charge resident, you would think you see all the patients. No, there's no way you can do it. You're just supervising. So you may have 12 interns under you. And you've assigned those 12 interns to each of these areas. And they're working with nurses. Okay? In the meantime, as the charge resident, you're putting out fires. If someone comes in coding, you're in on the code. Okay? If we have a complicated problem, you get involved. So one of the interns comes up to me that first week. Again, brand new doctor. He says, listen, I think we have someone who's dead on arrival. Yeah? And so the rule is, with regard to coroner's cases, is if someone dies within 24 hours of admission, or they're dead on arrival, that's DOA. They're a coroner's case. Don't confuse DOA with DOE. DOE is just the other version. So in any event, we have this patient that the intern says is dead on arrival. So I had a friend named Greg Cresson, who was the pathologist on call. This was getting toward evening time. And so I called Greg and I said, listen, I want to let you know we have a patient who's dead on arrival, because he's going to have to do an autopsy, basically. And so he was just finishing eating in the cafeteria, which was in the basement. And he said, well, I have the intern bring the patient down sometime this evening. I'll do it first thing in the morning. And then at the very end of the call, he says, wait, I'm going to knock this out now. I'm going to get rid of this. Have the intern bring the body down now, and I'll take care of it. And so, and he said, well, what's the case? Why is the patient dead on arrival? What do we have? And the intern says, well, apparently he had some type of stab wound, but I don't see it. And so I asked the intern this. No vital signs? He said, no. I said, no consciousness? No, nothing. I said, well, go ahead and send the body down. And so the pathology resident, when they first open up the chest, they do what's called a Y incision. An incision that looks like a Y. That allows you to split open the chest. Okay? Now, when they split open the chest, when it cut through the sternum, the knife not only went through the sternum, but then right behind it is the fibrous and parietal layer of the pericardium, like this. So he split that layer of tissue as he was splitting open the sternum. And as he split that layer of tissue, blood gushed out. And all of a sudden you could see the heart contracting, and the patient sat up. Okay? So the patient was actually alive. So he calls me back, I get a stat call, it's Greg Cresson, he says, this patient's alive. He was really animated. So I said, we'll send him on up, we'll take care of him. And so I bring the patient back up, and I get the intern, I said, let's go look at this. This patient's alive. So what happened was, he was in fact stabbed, but it was with an ice pick. And the ice pick had traveled up from his subxiphoid region into the ventricular cavity like this. Okay? And because an ice pick is very, very tiny in terms of its diameter, the two edges of the wound reapproximated, and unless you look closely, you didn't see a stab wound. Okay? And so, but it left a tunnel through the wall of the heart that allowed blood to escape and accumulate within the pericardial cavity. And as the blood accumulated, it began to compress the ventricle so that it was not allowed to fill with blood during vasculating. And so without ventricular filling, you can't generate any blood pressure. Cardiac output falls. So, when this intern went to listen for heart sounds, any sounds were muffled by this blood that had accumulated within the pericardial sac. That's called a cardiac tamponade. Tamponade. Okay. And so by releasing that blood that was compressing the ventricle was again allowed to fill and generate significant output so that the blood pressure climbed, all of a sudden he got cerebral perfusion and he awoke. Now, without being able to fill with blood or generate any output, the blood pressure is going to fall. You're not going to be able to feel a pulse. So he wasn't able to feel a pulse or hear heart sounds. The patient, because of an absence of cerebral perfusion, lost consciousness. He was actually breathing still. But the respirations were very shallow, so he didn't notice it. Okay? So in any event, this was an interesting story. You know, good stories make their way throughout the hospital. Greg Cresson was legendary after this. In the history of Charity Hospital, which was over 100 years, this was only the first reported case of a save by a pathologist. And I used to teach, he's like famous now. You know, he was in the annals of pathology now. Save, because usually pathologists work on people after they're dead. So this was this is an unusual case. It turned out that we kept him in the hospital for a total of 6 weeks for IV antibiotics because he developed a mediastinal infection. Why? Well, because with autopsies, you don't sterilize the tools. So he had an infection, but we treated him with IV antibiotics, and then we had the cardiothoracic surgeons come and wire back the sternum. But he lived. In fact, it was funny. Back in the day, he was placed in a ward where you might have 12 patients in one large space. You'd have visitors from other patients. And he would be telling them, yeah, I woke up in the bar. And he would look at the family and say, he was right. He did wake up in the bar. Things happen. Things happen at charity hospitals. But if you had to train someplace, like for instance, I trained at two different places. I trained at Charity Hospital, and then for my cardiac fellowship, I went to Oshner. Two vastly different experiences. At Charity Hospital, you can do anything. If I wanted to do brain surgery, I could do brain surgery at Charity Hospital. I remember as a medical student, I did my first appendectomy. Okay? Because there's not a lot of oversight. Like the real faculty don't really want to go to charity. Okay, they want to work at their private hospital. So as a result, you pretty much do what you want. Whereas when I went to Oshner, okay, everything was pretty highfalutin. You know, everything was well supervised. You had a lot of conferences every day, a different environment. So when I transferred from like Charity Hospital over to Oshner, I had already done procedures that maybe the chief resident had never done. You know, I already had much more experience than most of the people who had been at Oshner already. So, but it's two different worlds, and I can appreciate both worlds. But that's called a cardiac tamponade. Let's see now. There we go. This is a technologically advanced room. Now, you may recall that there are three vessels that enter the right atrium that return blood to the heart. In this particular image, we can only see one of those three vessels. Which one is this named? What do we call this? Superior vena cava. So the superior vena cava is returning unoxygenated blood from all parts above the diaphragm. Whereas the inferior vena cava is returning blood to the right atrium from parts below the diaphragm. What is the third vessel that enters into the right atrium? What is it?
No, wait. So that's on top, that's the.
So superior vena cava, inferior vena cava,
The.
coronary sinus. The coronary sinus is carrying unoxygenated blood from the myocardium back to the right atrium. So this unoxygenated blood is traveling to the right atrium so that it can then be pumped into the right ventricle and to the lungs. Or it can pick up some more O's. But unoxygenated blood needs to recirculate, pick up some more oxygen. Notice that when you first open the chest, you don't see the great vessels that well because the thymus is in the way. And the younger the individual is, generally the larger the thymus. As we age, as we get older, the thymus starts to atrophy. And part of it is replaced by fat. So as you age, your thymus actually gets smaller. Okay, the thymus is like the miraculous case of Benjamin Button. You know how as Benjamin Button got older, he actually got smaller, and then he ended up being a little baby at the end. You don't remember this case? Anybody? Okay, one of the assignments is to watch this movie. It's on Netflix. It's called what is it called? Y'all not seen Benjamin Button?
No.
It's Brad Pitt. Okay, so Brad Pitt is involved with Benjamin Button. Okay, it's not called the miraculous case. It's called something else, the mysterious case of Benjamin Button, something like that. And so when he's first born, he's born an old man. But as he ages, okay, at first, of course, he becomes young and healthy, and then he gets smaller as he gets older and older and older. But he's actually getting younger. Does that make sense? He starts off old and ends up young when he dies. He's moving in reverse. The analogy to the thymus is the thymus gets older, it gets smaller and smaller and smaller. Doesn't get bigger. 10 points, depending on when you watch this Benjamin Button. No good quiz. All right, so this is a busy slide that has all the information I've already provided. I'm gonna be truthful with you. When I first put together this PowerPoint, this slide was not there. What happened is when my wife started teaching, she took all of my PowerPoints, then she added very wordy slides like this. I felt more comfortable just talking about stuff, but she wanted to put it in print. So here's your information about the pericardial sac. You have the fibrous pericardium and the serous pericardium, which is subdivided into 2 layers. Okay? The visceral pericardium is called the epicardium. Okay? It forms part of the outer part of the heart wall. The other 2 parts of the heart wall are the myocardium and the endocardium. Okay? The heart is located in the mediastinum, apex, base. We said it all. We have argued a lot about this slide. I've told them that this slide is doing students more harm than good. Okay? Why do I say that? Because we're treating them like babies. Yeah. We've already said this stuff. You've already taken notes. I'm glad to hear you agree with me. All right, here's what we've done here. We've removed the parietal layer of the pericardium. How do I know that the visceral layer is still there? The visceral layer gives the surface of the heart this gleaming appearance. Okay? If you strip away the visceral layer, the myocardial layer looks dull. Okay? Now, notice along the anterior surface you have these fat-filled grooves.